Hi, my name is George Calixterio, and today I will be presenting an analysis of pediatric respiratory case involving a 4-year-old child named Charlie under my care. This presentation will explore clinical observations and nursing assessments utilizing evidence-based assessment frameworks that I will discuss later. I will also explore the identified problems, management strategies, and the importance of a child and family-centered care, recognizing that a child's emotional and social well-being is closely linked to their physiological health. Now, let's begin. So, what is influenza? It is one of the most common causes of pediatric emergency presentations and hospitalizations globally. According to the World Health Organization, influenza A and B are transmitted through respiratory droplets, making infection prevention and control critical from the moment of triage. Children under the age of 5, like Charlie, face the high risk of severe complications, and looking at Charlie's vital signs and clinical presentations point to respiratory distress requiring immediate intervention. Now, to give you a full picture, Charlie is a 4-year-old child presenting with several concerning clinical features. Her vital signs indicate tachypnea. She has a high fever and below normal range oxygen saturation, high pulse rate, and a borderline capillary time of 2 to 3 seconds. So clinically, she appears restless, crying intermittently, and demonstrates nasal flaring and wheezing. She preferred to remain upright, which suggests increased work of breathing. Her mother reported Charlie's reduced appetite and emotional distress due to missing her siblings. These findings collectively indicate a child who is at risk of respiratory deterioration and requires prompt and structured assessment for intervention. So in this case, I will have my initial assessment using the Pediatric Assessment Triangle or PAT. Charlie presents with several red flags indicating respiratory distress. Her appearance, crying, restlessness, and irritability suggest possible early cerebral hypoxia. Her work of breathing is abnormal, with nasal flaring and wheezing and a preference for sitting upright, all signaling an increased respiratory effort. Her circulation to the skin, shown by a capillary refill time of 2 to 3 seconds, is a borderline, and this requires close monitoring. So overall, the PAC provides an immediate impression that Charlie is experiencing significant respiratory compromise. Another assessment is the face, legs, activity, cry, and consolability scale, or FLAC. This is an age-appropriate behavioral pain assessment tool that supports structured evaluation of Charlie's discomfort. Based on her observed behaviors, Charlie falls into the severe distress category. This is clinically significant because unmanaged pain and distress can heighten respiratory effort, can elevate heart rate, and make ongoing assessments and treatments more challenging. So using the FLAC scale contributes to a more holistic understanding of Charlie's overall condition. And the third tool I will use is the Parrot framework. This supports early recognitions and escalation by combining clinical assessments with clinicians and family concerns. As applied to Charlie, it highlights significant respiratory compromise shown by her refusal to lie flat, restlessness, and distress. She remains alert but relies heavily on her mother for comfort, reinforcing the need for child and family-centered care approach. Molly's concern about reduced eating, risk of dehydration, and Charlie missing her siblings reflect important psychosocial factors that must be integrated into the overall care plan. So after referencing the three assessment tools for thorough assessment, I will proceed using the ABCDE framework. As I go along, any abnormal findings I will encounter, I will immediately do my nursing interventions. I will start Charlie's assessment by confirming the airway patency, and this is patent at the moment as evidenced by her ability to cry while noting nasal flaring and wheeze as a sign of increased effort and lower airway obstructions. Under breathing, her fast, shallow breathing, low oxygen saturation, the wheezing sounds, and the use of accessory muscles indicates impaired gas exchange and significant respiratory distress. Maintaining her preferred upright position is essential to avoid worsening her work of breathing. Management priorities includes providing supplemental oxygen using the least distressing device such as a non-breather mask or nasal bronze. administering inhaled salbutamol via spacer if wheeze persists, and reassessing her response every 15 to 30 minutes. Failure to improve would require urgent escalation for potential high-flow nasal cannula oxygen or advanced respiratory support. Charlie's circulatory status shows tachycardia, likely driven maybe by distress, fever, and compensatory responses to hypoxia. Although her blood pressure is normal, she remains vulnerable to reduced cardiac output and fluid deficit. So, establishing IV access is essential for timely medication and fluid support. Under disability, she's alert but anxious and fatigued, and her fever requires prompt management to reduce metabolic demand and prevent febrile seizures. So, paracetamol is appropriate. Ibuprofen can also be used cautiously and should not be administered when dehydrated. Or aspirin is contraindicated in some cases. Blood glucose must also be checked due to her poor food intake. For exposure, assessing hydration status and performing a full head-to-toe check including skin turgor, mucous membranes, rashes, cyanosis, edema, and urine output is crucial to identify dehydration and rule out serious infections such as meningococcal disease. So after these thorough assessments, Charlie presents with several nursing problems. This includes respiratory distress, fever, tachycardia, increased respiratory rate, and reduced appetite. Potential problems includes dehydration due to poor oral intake, which can further compromise respiratory functions. And lastly, emotional distress as related to separation from her siblings. Supporting oral hydration with small frequent fluids and involving Molly in this process is essential. Facilitating virtual contact, maybe in a form of video call with her siblings, may also reduce anxiety. Recognizing both actual and potential issues enables early interventions, prevents deterioration, and recognizing several symptoms can reduce the risk of transmissions. Also, child and family-centered care is an essential component of clinical practice. For Charlie, this involves actively including her mother, Molly, in decision-making, offering reassurance, and communicating clearly. According to Sinawat et al., effective care is grounded in partnership, communication, collaboration and participation, respect, dignity, and compassion. This is reflected considering Molly's insights, such as noticing changes in Charlie's behavior and appetite. Her involvement and the twins' participation during the process are clinically valuable. Communication must be tailored to both child and parent, using simple explanation for Charlie perhaps, and a clear jargon-free language for Molly. Respect involves supporting Molly's parental role and encouraging family participation, including maintaining social connections with the twins to reduce stress. Compassion ensures Charlie is seen as a whole child with emotional and psychological needs and not just a clinical case, and this can ultimately promote trust and better health outcomes. With regards to discharge planning for Charlie, this focuses on ensuring Molly is confident in managing Charlie's care at home. This includes understanding of medication administration, monitoring symptoms, and encouraging appropriate nutrition and hydration for Charlie, and knowing the required follow-up checks. I will also provide Molly with written red flag signs that warrant urgent return to the emergency department, as stressed caregivers may not retain verbal instructions alone. Medication guidance must be clear and weight-based to prevent dosing errors. Education also should include the importance of the annual influenza vaccinations for the whole family to reduce future risks. I believe that effective discharge teaching can strengthen parental confidence, support safe recovery at home, and reduce the likelihood of readmission. So, in conclusion, Charlie's case demonstrates the value of the structured evidence-based pediatric assessments in recognizing early deterioration. Frameworks such as ABCDE, the Pediatric Assessment Triangle, PARROT, and the FLUX scale support systematic clinical reasoning and guide timely interventions. Effective management focusing on stabilizing respiratory function, controlling fever and discomfort, maintaining hydration, and monitoring for further decline. Equally essential is a child and a family-centered approach that addresses emotional and psychosocial needs. Together, these elements highlight the holistic nature of pediatric nursing, integrating clinical expertise with compassionate, family-focused care. And here are my references. And the last one, thank you very much.